Morning. Welcome to another session of short course in clinical epidemiology. So today we are doing a design which we have not done before, though it has got some similarities with the previous study designs that we have discussed. This will be a critical appraisal of a quasi-randomized control trials or a quasi-experimental study design. We have done randomized control trials, we did one last week as well, and we have done some observational study designs as well in the recent past. But there's somewhere in between. So we are once again happy to have Dr. Anuka who will take us through critical appraisal of a quasi-experimental study design. We do not have a CAS checklist for this particular study design, but there are some other resources. So Dr. Anuka has reached one Joanna Briggs Institute JBA checklist for the same, and will be critically appraising an article, and will also show us other resources that we can use for assessing the validity of a quasi-RCT. So I hand over to Dr. Anuka for the same. Once again, if any of the audience have any questions, please feel free to post them in the chat box. Or once the session is over, we are happy for you to unmute yourself and ask your questions. Thank you, Dr. Anuka. I'll hand over.
Good morning. Today we will look at a new checklist, JBI checklist for a quasi RCT trial. So today the outline of the talk would be what is a quasi RCT. We are very familiar with a randomized control trial. We have actually had multiple sessions on the same. And what are the tools we can use as a checklist for a critical appraisal for a quasi RCT. So we will look at two tools. One, a brief introduction about the Robin I tool, and we will today go in detail for the JBI checklist. Now this is the hierarchy of study types. If you look at the hierarchy, the best evidence we get is from either a systematic review or the meta-analysis. Below that are the experimental studies, and below that are the observational studies. If you look at the experimental studies, we can have a randomized control trial, which we are more familiar with, or a non-randomized control trial. So just continuing on the same, so the non-experimental, that is the observation study design, can be a cohort or a case control. So sometimes there can be comparison group or sometimes it's not there. But looking at the experimental design, in a RCT randomized control trial, we know that there are two groups. Participants are randomized either to the treatment or the control group. You can measure outcomes for both groups. We know there's evidence, it's a very good evidence, and then it helps us to compare between the group. Now, for all the studies, we cannot, usually we do experimental group in which there is an intervention, and sometimes we are not able to randomize people into groups. So that comes the quasi-experimental study design. So here you can measure outcomes for the participants. There is a control and an intervention group. They are not randomly assigned. So there is a control for bias and a comparison group, but it's not randomized. So in a classical design, we know there's an intervention group, control group. They are randomized into two different groups, followed by the intervention, and post-intervention we look at what is the difference. In a quasi-experimental design, there is no randomization. There are two groups. We can have either only a post data, or we can have pre and a post data, and we can compare. So it's a pre-intervention data. There is an intervention without randomization and a post-intervention data. Looking at details, we will look at the if they are randomized or not randomized. So if there is an intervention and your question is what happens after the intervention, if it is randomized, we know that it's a randomized control trial. If they cannot be randomized, we can have either only after only design, that is only the post-intervention design, or a pre-test, post-test design. So today I will be looking at a quasi-experimental design, which is a pre-test, post-test design. Now, we know RCT is very good, but there are some pitfalls with RCT. It's very time consuming, it's expensive. Sometimes it may not be ethical. For example, in vaccines in children or in some pregnant women, it may not be feasible. So to overcome these pitfalls, we can do something called a quasi-experimental design, RCT. So it has an experimental and a control group. Allocation may not be random, or they are not randomized. It can be used when the randomization is unethical or impractical. It's more feasible and cheaper than RCT. It's the same thing which we looked at. So only limitations are there is a selection bias. Before we give the intervention, what is the selection bias? You can have some manipulation, so you don't know the validity of the study, and there can be more confounding there in the RCTs. So case for today. So last month we had a audit by the intern in our C board, and we found that there was around 94% of some amount of drug-to-drug interaction, out of which 5% was seen drug-to-drug interaction. So one of the solution to that which was described was the online EMR which we have, online pharmacy, that should show a drug-to-drug interaction alert. Now we want to know how effective is a alert, drug-to-drug interaction alert while prescribing. Does it reduce a drug-to-drug severe interactions? Now to answer this question, we will be looking at effectiveness of a comprised alert. We look at both clinically significant interactions and a drug-to-drug interaction related harm. So this is a quasi-experimental control pre-post study design. We are familiar with CASP for RCT. CASP is not available, as I said, for a quasi-experimental study design. One of the tools is risk of bias tools. So we have covered risk of bias tool before for a crossover and for a cluster RCT. If you look at, this is a web page for the risk of bias tool. So ROB2 tool is for a cluster, for RCT cluster or a crossover RCT. If you go down, Robin SI, this is a risk of bias in non-randomized study of interventions. So this tool can be used to assess the risk of bias in a non-randomized intervention study. This is how it looks. It looks at 7 domains. It looks at risk of bias due to confounding, due to classification, due to selection, or any deviation from the intervention, missing data, measurement of the outcome, or selection of the reported result. So each of these bias, there are possible yes, no, probable yes, probable no. And based on that, it gives either a low risk or a moderate risk or a serious risk or a critical risk. So if it is a critical or a serious risk, probably the validity of study is not good. Today we will look at another checklist, which is a JBI checklist. To look at the internal validity, and we'll use a CAP for the result and the external validity. This is how the checklist looks. There are 9 items. For each, you can answer as yes, no, unclear, or non-applicable. At the end of your appraisal, we can decide can we include the study or exclude or seek further info. Going to the study for today, the pivot statement. So population, here they looked at the population was number of admissions. They looked at admissions. They took 5 hospitals, admissions in 5 hospitals. Intervention was in implementation of a severe drug-to-drug interaction alert. So all of the hospitals used the electronic medical record, EMR. So if you use the EMR, the intervention hospital had an alert, interruptive alert, which pops out. And the control hospital was using the same EMR without alert. The primary outcome they looked at was clinically relevant DDI, that is drug-to-drug interaction. Secondary outcome was potential drug-to-drug interaction or a DDI-related harm. Why did they choose this design? So they chose a quasi-experimental pre-post design. So this was at 5 hospitals in 2 Australian states. This was a retrospective patient record review data. So because of the retrospective data, here randomization was not possible because some sites had already DDI alert, some sites did not have DDI alert. So they had 3 control hospitals which use EMI without the DDI alerts. So they had 2 types of databases, Cerner Millennium or a MedChart, and 2 intervention hospitals which use EMR with the interrupted DDI alerts. So going to the questionnaire, the first question is it clear what is the cause and what is the effect? The cause is what is the intervention. So your intervention was an interruptive major severity DDI alert. And outcome which they looked at was, they looked at 3 outcomes: potential DDIs, that is potential drug-to-drug interaction, clinically relevant drug-to-drug interaction, and DDI-related harm. So they measured data both pre and post implementation. In the checklist you're looking at, is there a cause and effect? Is the cause preceding by the effect? That is fulfilled in the study. So this was their clinical decision support. This is their EMR. So once you order, for example, somebody has ordered rivaroxaban and warfarin, and it gives an alert saying this is a major contraindicator. After you get an alert, there is action. You can either override reason, or you can say, oh, we have applied clinical judgment, and you have to give something, and then only you can continue. So this is the intervention. So this is how they looked at drug-to-drug interaction. And this is the outcome. So there are 3 outcomes. It was well defined. The potential DDIs where any interaction where the effectiveness is altered. Clinically relevant is interaction with taking into account if there's any toxicity or a reduced effectiveness. Harm is, which they have defined harm as any serious structure or function of the body. Any suffering, any disability, any physical, social, or psychological harm. So these were the 3 outcomes they looked at. Second question was where the participants included similar. So this was not a randomized trial. Here the participants were quite different. I wanted to look at control and intervention pre. This is a baseline characteristics. So if you look at that, you see that female patients are more in the control arm. Age group is more in the control arm, so that might have adversely affect. This is a number of admissions. So admissions are fairly similar. But if you look at the intervention arm, the number of orders, that is the median number of orders are more, 14 versus 9. Number of drugs, we know that more the drugs, more interaction will be, more at the intervention arm. So they must be starting at a lower level. And this is a number of potential DDIs. So that is also more, probably because the numbers are more. And the clinically significant DDIs, if you look at that, is 1 versus 0. Probably because here the number of admissions and the number of drugs are more. The next question is where the participant included received different treatments. So here both the groups use EMR. Only difference was the alert enabled or not. So they had 2 vendors for the EMR. They had intervention group, all of them use Cerner Millennium. In the control group, there are 2 different EMRs. Here, because of the variability, they have excluded ICU and oncology wards. But there were some other differences which is not mentioned. One is hospital level differences. We don't know how 5 centers they have taken to what is the level of the hospital. Second, prescription differences. They might have a different preference in different department or a hospital policy. Treatment protocol. They have not mentioned who are the prescribers. The expertise level of the prescribers might be different. So some people would have anticipated and that would not have resulted in that. Co-interventions is not mentioned and they have excluded ICU patients. They have taken ward admissions also. So the sicker and where you expect more interaction, they are actually excluded. So this would have probably there would have been some co-intervention or some differences which is not captured here. Next question is, was there a control group? Yes, so this study, quasi-experimental design, they had a control group. So JBI looks at, is there a control group? And if there are multiple pre-post measures, you can reduce, you can have a better resiliency. So, if there is a control group, we can use it for comparison. So here in this study, there was a control group. Next question was there multiple measurements of the outcome, both pre and post intervention? So here they had only 1 measurement. So they had done sampling from 1 week, 6 months before the implementation of the EMR and 1 week, 6 months after the implementation. If there are multiple measurements, you can have probably a better precise results. So here they have done only 1 week pre, 1 week post. Next question was the follow-up complete? So this is usually how we see in RCT. You have a longitudinal cohort, you follow them, after intervention you follow them. This study was not a longitudinal cohort of patients. This looked at multiple cross-sections of multiple admissions. So there was a repeated cross-section. So we are worried about follow-up, loss to follow-up, attrition bias, that probably will not be applicable in this study. Next question what's the outcome measured in the same way? Yes, so the outcome was DDI, drug-to-drug interaction. So the data was collected retrospectively from the medical records. So they had a team of clinical pharmacists with different various years of experience. they had a data collection guideline. All of them received training and they had several practice rounds before the study. They had an expert panel to classify clinically significant GDIs. Out of, for them, the inter-rater reliability testing Cohen's kappa was 0.8. And post-EMR period, to look at the post-EMR period, the data was extracted from the EMR, from the EMR rather than from the inpatient record. All the data they are taken from the EMR. So this is the checker they had used. So they had Stokely's interaction checker. This is how it looks like. This tells you if there's a drug-to-drug interaction. So they had done a detailed audit of the patient's record, and they looked at potential drug-to-drug interaction. Then they had looked at risk versus benefit. What are the contextual factors? And each of them was rated as very unlikely, unlikely, possible, or likely. Only the possible or likely was taken as a clinical relevant DBS, which was the primary outcome. So this is, they have given how they have done. So they had a detailed audit. They looked at moderate to severe. They looked at what was the potential DDIs. They had reviewed and seen if they are clinically relevant. All the clinically relevant DDIs was reviewed in depth. Looked at if there's a harm, because they had one of the outcome was potential DDI related harm. And this was done by expert panel, which was blinded to the group, intervention versus control, or a period, pre or post. So if there's harm, they had DDI related harm or no DDI related harm. So both were similar in both the intervention and the control group. So they have actually given what are the contextual factors they have taken. They have seen how they have put the level of the harm, which is minor, moderate, serious, severe. They have also given what is the possibility of harm, certain, probable, possible, unlikely. So they have actually given each definition for each of the things they have mentioned. Where the outcomes measured in the reliable way. So they had looked at Cohen's kappa, which is a inter-rater reliable testing. So if you how to interpret it? So less than 0 is poor agreement, 0.8 to 1 is almost perfect agreement. This was around 0.8, substantial agreement. So we can say there's 80% chance of good correlation between that. In a statistical study, that is a very good reliability. After this, they had an independent abstraction with team review of difficult cases. So this outcome was measured in a reliable way. Was the appropriate statistical analysis used? So they had done an intention to treat analysis, and they had used a generalized estimating equation model. So what is that? This is a model developed in 1986. They used to analyze correlated data. What is correlated data? For example, if you have repeated measurements over time, one patient multiple blood pressures, or repeated HbA1c every 3 months for 2 years. So how do you analyze the data? We know that this is correlated. It's a repeated measurement. Or it's just clustering. All the patients are from the same hospital or from the same physician. So there is a inter-cluster relation. Capture that as compared to a linear models, we can do a generalized estimating equation to capture clustering data. So either repeated measurement or clustered measurement. We can use this model to capture the vision. So this is appropriate in this study for a pre-post comparison with repeated admission. So they have done appropriate statistical analysis. They use this model with a group into period interaction, and they are adjusted for sex, age, number of drugs, and clustering. They had power calculation was presented. It was revised because COVID-19, they had some problem in collecting data, and the analysis was performed using this software. So this was the last question in the checklist. I have also included sample size collection. So pre-study, the sample size was based on a previous study which showed that at least 56% had one potential DDI. So they had estimated a 25% difference to be clinically relevant. So the sample size was 2,800 for a 98% power with a 5% level of significance. But because of COVID-19, they had problem in collecting data. So they had recalculated sample size based on the data collected up to May 2020. So till that time, the proportion of admissions with clinical relevant data, DDIs, was around 44%, assuming a 35% reduction with a 80% power with a 5% alpha error, two-sided alpha. The sample size calculated was 1,740. what did they do? So they had reviewed 2078 records and they had taken 1058 admissions. So they had actually not fully reached the sample size. So 1058 in the pre and 1050 in the post.
Just one thing, huh? That 35%, do you think it came down from 44 to 9%? Was that their estimation? If it was 44% in the non-intervention arm, and the reduction is 35% assuming. When you do sample size, you don't know what's going to find. They're assuming 35% reduction. That is the same from 44 to come down to 9%.
35% or 40%.
So it's relative risk, relative reduction. Is that right? Good. You understood. If you say that absolute reduction is 35%, I'm assuming sample size is done before the study. If you say like this, I will study enough people. If the absolute reduction you're saying is 35%, that means without the intervention it will be 44%. If you come down by 35%, that means 44 minus 35 is 9. So it will come down to 9% is my assumption. If that is a huge assumption, sample size should be very small. You won't get a sample size of 1,700. You will get 200, 300 because it's a huge. You are assuming it's going to be miraculous intervention. Actually, the sample size is large because 35% of 44. What is 30% of 40? Roughly 3 to 4, 12. So from 44 it will come down minus 12 about 32%. That's why the sample size is so. The statisticians especially write sample size. Either you can do absolute reduction or you can do relative risk, relative reduction. This 35% is a relative reduction. It looks nice, we assume 35% benefit. Suppose the baseline risk is 10%. What is 30% of 30% reduction? 10% of 3, 3% of 30% of 10 is 3, roughly 3. So from 10 it will come down to 7. So be very careful. Everything depends on your baseline risk. Just play that.
Other data which is not there in the checklist, the funding was by the National Health and Medical Research Council. They had no role in the study. Blinding, so they had the outcome assessor, that is the expert panel was blinded to group. But the study pharmacists who looked at the DDIs were not really blinded to group or the site theory. Ethics approval was taken. So coming to the checklist, if you look at the checklist, based on the parameters in the checklist, this is a fairly okay, well done study. So I have included. Going on to the result, we will be using the CAS checklist for the result. Where the effects of intervention reported comprehensively. So these are the questions we are trying to look at. Was the power calculation done? Yes, we will come to that. Outcomes were measured and they were specified. They had results were expressed in either odds ratio or adjusted odds ratio. They had not, here is not applicable for follow-up. Missing data not applicable, they have taken all the data. Differential follow-up not applicable here. So they had also identified some sources of bias. Statistical tests we had already covered, p-real values were reported. So coming to the results. So this was a primary outcome, clinically significant drug-to-drug interaction. So if you look at the control versus intervention, the odds ratio was 1.07 with a very wide crossing one confidence interval. So this was not significant. Even after adjustment, this is not significant. This was all the potential DDIs. There was 0.8 with the confidence interval crossing one not significant. But after adjustment, it was 0.38, around 72% reduction with confidence interval on the same side. Looking at the admissions with harm, so this is DDI with harm, that was also not significant with a very, very wide confidence interval. So this was the.
So what is the percentage in the CDDI? That is the primary outcome, right? What are the percentages in the two arms? Intervention arm? 57%.
Pre.
No, post, no.
57, 40.
So higher number is better, lower number is better.
Lower number.
So the control group had lower CDDI. That means a bit better.
Yes, sir.
Should it be the other way? Shouldn't the intervention arm have done better?
Yes, sir. Actually, if you look at the baseline, they have actually given the numbers for that. Very surprisingly, they are. So they have given post and pre values. If you look at the number of drug-to-drug interaction for admission,
for this.
both is more.
Okay, so
Actually, it has increased after the intervention and the clinical significance. Both the
just go back to the results table. So, according to this results, the CDDI is 42 in the control arm and 57. Which actually we thought it will come down from 50 to 30 something. It has gone up from 30 to 57. Even if you adjust for the fact that at the intervention arm potentially started off with a slightly worse outcome. Still that. Because an odds ratio of 1.1 is statistically increase in risk. Odds ratio less than 1 is protection. It was actually increasing in risk. It's difficult to interpret that.
We were thinking probably those cohort of patients would have been quite different.
Because they didn't follow the same people, so different cohort of people. Okay.
This is one of the secondary outcomes. They looked at harm pre and post. So this is just for the numbers. So they have actually given the numbers of each of the harm associated with the DDIs. So if you look at it, these are the boxes you look. Pre-EMR in the control group was 57, post-EMR was 19. But here pre-EMR is 33, post-EMR with alert in the intervention group somehow has increased to 90. So just the only way to explain is probably they were sicker patients with more admissions in different cohorts. So the next question is the precision reported. Yes, they have reported confidence interval, but it's a very wide confidence interval, very imprecise result. The harm reported, yes. Was a cost-effective analysis done? Here it's not done. But here EMR is part of their daily, for them, I think all of the hospitals use EMR. It's just a matter of alert starting or activating the alert or not. So maybe for them, cost may not have really made a difference. Coming to the third part, external validity. Will it help locally? So can it be applied to a local population in your context? So here the participant details, so the type of patient they have not explained. The drug database for both the EMR they use is something called Oracle Health Malta. CMC we were looking at here, we have our own database, we have actually developed our own database. So database usually determines what type of alert is given. Maybe that might be different. Outcomes, yes, outcomes are important for us. Some of the limitations here is study pharmacy is not blinded to size. So the outcome here was a DDI, which they had taken retrospectively from the EMR. So maybe if they knew it's a control hospital or an intervention hospital, then the amount of them capturing the data would have been difficult. There is validity issue with the study, baseline imbalances, possible co-intervention, very small sampling window. And they had excluded ICU patients. So that all would have a probably limitation for this study. Would the experimental intervention provide greater value into the patient than of existing intervention? So here, based on this study, they didn't show any much clinically difference in the clinically significant DDIs. But the things which can be done is you can tailor the alerts. So here they taken moderate and severe both. You can tailor the alerts, maybe the outcome would have been different. I was looking up for a EMR. One of the things there is there are multiple alerts, something called alert setting. So if you clearly determine what are the alerts you want, maybe it might make a difference, but this study currently won't be able to answer that question. So we also have a EMR, we also have a pharmacy with the alerts. So probably for research perspective, it may not be very different from our setting. So coming to the clinical question, will the alert be effective in the EMR? Based on this study, for the clinically significant drug-to-drug interaction, it has not shown any difference. The only thing is it has picked up more potential drug-to-drug interaction. Will there be any clinical benefit from that? We can't really say based on this. Thank you.